क्या
भास्कर
हुआ?
कितना लंबा लेक्चर लोगे? भास्कर कितना लंबा लेक्चर लोगे?
डिपेंड करता है मैडम, आप लोग चाहे तो 1 घंटे में खत्म कर दूंगा, अगर चाहे तो 2 घंटा भी लगा सकता हूँ। ये आप लोगों के ऊपर।
आपको चेयरपर्सन ने
आप लोगों
कितना मोहलत दिया है?
मेरा कोई प्रॉब्लम नहीं।
उसको सेंसर कर देंगे उसको।
चेयरपर्सन के हाथ में है कमांड, भास्कर आपके हाथ में नहीं है, वो डिसाइड
हाँ,
करेंगे।
इसीलिए वो लोग जितना डिसाइड करेंगे मैं उतना बोलूंगा, जितना ये तो उन लोगों के ऊपर डिपेंड करता है।
ठीक है,
बट एक चीज बोलूंगा,
श्रेया,
am I audible?
Yes, sir, sharing.
full screen please. So my 135th welcome to all of you. Thursday musings. Today's topic is psychopharmacology of brain, basics to applied, part 2. Some part we'll discuss today. Next slide please. I'm handing over the session to Professor Dr. Tufan Pati sir. Sir, over to you. I'm not reading your slide. Please return the favor to us.
Thank you very much. So we start this meeting, and I will formally mention about our vibrant moderators, Dr. Alim Siddiqui and Dr. Amrit Pattudusi. And please gloss over their slides so that we go to the slides of the chairpersons. Please forward the slides. Next slide, please. Dr. Amrit Pattudusi. And next slide, Dr. Alim Siddiqui, our vibrant moderators and the backbone of the program since the outset. And our chairperson, Dr. Sujay Vijay Jaiswal. He has been trained in Government Medical College, Nagpur, Maharashtra. And
previous slide.
No. Yeah.
Next
Yeah. Slide.
Yeah, sir.
Jaiswal, All India Institute of Medical Sciences, Nagpur. And he has education is in Government Medical College, Nagpur, Tokyo National Medical College, Mumbai. Teaching experience, senior resident, Department of Psychiatry, LLM Medical College at General Hospital, Sion, Mumbai, and assistant professor, Department of Psychiatry, HNT Medical College, and Dr. R.N. College, Mumbai, General Hospital, Chuhu, Mumbai. Presently, associate professor, Department of Psychiatry, All India Medical Sciences, Mihan, Nagpur, Maharashtra. Number of publications in national international journals, there are many presentations. And welcome, Dr. Vijay Jaiswal. Next, please. Next slide, please. Next slide, please. Dr. Malay Dave, again, welcome, Dr. Malay Dave. And we are meeting here frequently. He is consultant psychiatrist. Dr. Malay Dave, slide, please. And he has been awarded with the Bombay Psychiatric Society Silver Jubilee Prize and Bhubaneswar, January 1999. Won Dr. Anil V. Shah Best Paper Award in 29th and ASIFS, Question Journal Branch, Mumbai in 1998. Area of interest, neuroscience, genetics, and publication to his name. He is a good speaker and master of the subject, and he will be. Now, henceforward, the meeting goes to the chairpersons. Please take over. Dr. Jaiswal and Dr. Dave, the meeting is yours. And one of you, please introduce our speaker, Dr. Bhaskar Mukherjee, and the topic, and we go on with the topic.
Yeah. Good evening, everyone. Am I audible?
Yes, sir.
Yeah. Good evening, everyone, and thanks, Dr. Tufan Pati, Drs. Alim and Amrit for inviting me, and Suyog to chair this session. First of all, welcome, Suyog. You have been my student throughout your MD at Nair Hospital, and it's very nice to see you here along with me, now an esteemed colleague from AIIMS Nagpur. about Bhaskar. Bhaskar has been a frequent visitor at Thursday Musings. All of us know him. He is a molecular neuroscientist, as he would like to call himself.
No.
But
Student of molecular neuroscience, not neuroscience.
no, okay. He's a student of molecular neurosciences. But apart from that, he is an astute clinician, and he has got a huge patient load, not only in his native state, but also helps us all over the country, and maybe those of us who have logged on from overseas. He has been kind and generous with his advice when it comes to patient management. In times of difficult situations, he is always there to help us. We have heard his first talk on the psychopharmacology of the brain. We are waiting, Dr. Alim, for the link so that we could go over it again. Having said that, Dr. Suyog, would you like to give us something before we start?
Yes, sir. Thank you very much for inviting me here, sir. And one thing that I really stuck to me, sir described himself as a student of molecular psychiatry. That is an interesting thing. This humility generally comes from when you know the vastness of the knowledge that is there in a particular field, and then you find that there is too much to know. And though that you have learned quite a lot, there is a lot to learn. So I understand a lot of learning that sir has and a lot of knowledge that sir has. Sir will enlighten us here about his knowledge, and we'll go a bit wiser at the end of this session. Over to you, sir.
So, Dr. Bhaskar Mukherjee, over to you. It is around 8:12 now. So maybe for the next 45 to 50 minutes, we would like to hear. Let's see how it goes.
Give me 1 hour.
Okay. But we'll warn you after, we'll warn you when it is 50 minutes.
Okay.
Yeah. Okay. Over to you, Bhaskar.
So let me share my screen. Start first. So this is the second installment of molecular psychopharmacology. There are plan of 9 installments altogether, and there would be, let's say, not that there would be gap in between them. Let's say after one installment, there will be 2 to 3 months gap, then another installment. Because if I continue this as a series, it would be very hard for people to even grasp it. So standing there, let's start. Am I audible?
Yes.
Am I audible?
Yes, Bhaskar.
Because someone said that I'm not audible. So today's topic is molecular psychopharmacology of depression, anxiety, somatic symptom, and the whole thing. And this is actually the end. The end means this is the state of brain failure. If we correlate with heart, it is like congestive cardiac failure. And just like congestive cardiac failure has millions and millions of reasons, similarly, these symptoms also has millions and millions of reasons. And let me first warn you, those of you who want to be agony aunt or agony uncle, motivational speaker, life coach, they should live with this title slide, because next is coming the proverbial rabbit hole. And if you learn this, you are not going to be successful as agony uncle or agony aunt. So let's second. This is the flow of talk. I would not follow it But still, basic brain-based pathology as usual, then approach and evaluation, then initial stage treatment, then later stage treatment, then residual stage treatment, prognostication, patient education, future and endpoint. This is just a formal way that this talk would flow. I would not stick to it, and I would jump many times, and I would also take a few detours. So basic nervous system functional segmentation and working division. Why we need to know this? Without knowing the basic, we cannot apply that basic directly to bedside. This is a presentation of translational neuroscience. What I would talk today would be directly applicable tomorrow onwards. You can apply it, but for that, you need to know the basic nervous system functional segmentation. For many of you, it would be a revision because I have talked about this in my other lectures. So I would skip this part mostly because most of you already know these things. What happens in brain is the master of homeostasis, and homeostasis is a dynamic functional balance between external environment and internal environment. Homeostasis adjustment is the basis of our adaptability to social environment, external environment, and internal environment. Brain controls homeostasis through thousands of regulatory brain processes working in tandem. It is not actually thousand, it is probably trillions and more than the number. But I don't want to scare you. So for now, just understand there are thousands of regulatory brain processes and they work in tandem to maintain homeostasis, because ultimately brain evolved to maintain homeostasis in a vertebrate animal's body. So how brain regulate the homeostasis? There are autonomic nervous systems, there are endocrine, neuroendocrine system, there are immune system, and other regulatory nervous system. Now, this other regulatory nervous system is also divided in cortical regulatory nervous system, subcortical, spinal, and peripheral nervous system regulation. From peripheral nervous system regulation, I am starting the journey of Wonderland. Remember, most of the time, pop neuroscience talk about gut is the second brain. They are mistaken. Gut is not the second brain. The number of second or third or fourth brain we don't know. First, in top of everything lies brain and CNS, the original brain, the original regulatory system. Through autonomic nervous system, through neuroendocrine system, and through immune system, they control intrinsic nervous system of heart. Now, intrinsic cardiac nervous system or intrinsic nervous system of heart is a hugely detailed nervous system, and people are doing very active research on it. I would show next 2 slides on that. That is the basis of all other intrinsic nervous system. Anyway, first there is intrinsic cardiac nervous system, then there is intrinsic lungs nervous system, then there is intrinsic enteric nervous system, which is erroneously and marketing wise hyper enthusiastically called second brain. Then intrinsic nervous system of bone marrow. This is probably the largest intrinsic nervous system. Then intrinsic nervous system of skin, second largest intrinsic nervous system. The intrinsic nervous system of whole vascular system, probably jointly tied as second. reticuloendothelial systems, intrinsic nervous system, and other various intrinsic genitourinary nervous system, other various intrinsic nervous system. For example, thyroid itself has its own intrinsic nervous system. Similarly, pituitary has its own intrinsic nervous system. Adrenal gland has its own intrinsic nervous system, and we don't talk about that. But each of them regulate these organs, every function, and through autonomic nervous system, neuroendocrine system, and immune system, brain control these intrinsic system. So, brain becomes the overlord of everything in body, everything. A mosquito bites in my tongue, in my leg, and I just felt the sensation. In between them, my brain, besides feeling that sensation, already activated the intrinsic nervous system or vascular system to do a preliminary vasoconstriction job of that part of skin, so that the blood flow to mosquito is less. Then the reticuloendothelial system has already been activated to start producing increased immune cell. Then the bone marrow, intrinsic nervous system of bone marrow has already been activated to produce more blood cell in the anticipation that I am going to lose some blood. This much adjustment and this much micromanagement our brain does. And this is what is psychiatry. So it is a body of brains. Every organ has one, and these brains are very complicated, moderately self-sufficient nervous system, which act as final control of these systems. Then CNS bidirectionally talk with them, and based on that, organ system function. Multiple brains means there would be multiple stability. It is very hard to destabilize nervous system because of these multiple brains, but they come with their inherent problem too. Each organ, as it is intrinsically controlled by its own intrinsic autonomic nervous system, CNS doesn't have to activate every time when there is a problem, unless the problem is serious and the intrinsic system cannot control. But this creates a counterproductive, complicated problem. Let's say intrinsic cardiac nervous system started falling, as it frequently happens in case of AMI. What would happen is CNS would start getting increasingly involved in management of intrinsic cardiac nervous system. Then that would create additional pressure on brain. Brain would start disturbing other intrinsic nervous system. That is why during AMI, peripheral vasoconstriction occur, which should not occur because that is actually making heart prone to failure. But that is happening because brain cannot restrict its hyperactivation. And then what compounds this single problem is brain doesn't know when to stop. When an organ is failing, brain would try to make it work more. For example, in CRF, kidney is deficit in handling the blood flow. But if you go through physiology of chronic renal failure, you would understand brain has started dilating the renal arteries to send more and more blood to kidneys so that it can recover, but it is becoming counterproductive, and brain is causing the organ to fail more rapidly. So these two complications has a very interesting implication for psychiatry. Yes, Alim.
Bhaskar, somehow my picture is coming on to your slides. So can we minimize it?
हो रहा है
हाँ,
कैसे आ गया एक मिनट ठीक है मैं उसको उड़ा देता हूँ
हाँ हो गया yeah it's done
हम्म,
no it's done हाँ carry on. No it's come again have you pinned it to the this thing is
आलिम को पसंद आ गया ये आलिम को ये पसंद आ गया ठीक है तू छोड़ दे तुझे मत योर पिक्चर इज देयर दैट इज एक्चुअली गुड बिकॉज आई वुड गेट सम फीडबैक के मेरा लेक्चर लोगों को सुनाई दे रहा है या नहीं दे रहा है सो तू अपने को देखता जा ठीक है सो व्हाट these two features tells us okay if during failure of other organs if we manage to stop the hyperactivation of brain we would actually positively contribute to the organ's recovery means in AMI cardiologists have a role psychiatrists have a role in CRF or ARF cardiologists have a nephrologists have a role but at the same time psychiatrists have a role and that is true for every organ system so psychiatry is part of every medical discipline due to this is intrinsic cardiac nervous system I know this picture looks very complicated just understand that this is higher brain this is spinal cord of and they are they are actually innervating every part of heart musculature and controlling the epicardial blood flow as well as electrical generation as well as everything this is a more simpler picture but it lacks the intricacies but it is also showing the same higher center through medulla and spinal cord neuron actually controls intrinsic cardiac nervous system so with that done with multiple brains in throughout body firmly revisited some more basics needs to be shared we already know that if brain is controlling homeostasis and through micromanagement then that micromanagement has to have a functional range beyond that functional range that micromanagement is going to be in a state of failure now what is that functional range that functional range is a genetically determined range so when brain is acting normally let's say we are doing our daily regular job that functional range is not breached but when there is a demand on brain to perform outside this functional range to manage some disturbance in homeostasis brain got into a functional demand mode and that is called stress so that this stress that stress so many stress in psychology has no meaning biological meaning of stress is that functional load that makes the brain work beyond its normal functional capacity there are a sequence of events that happens when brain is falling into that area so the precise molecular steps are in this flowchart most of you know this flowchart so I am not going into details of it because we are going to much beyond today increased homeostatic load would cause high information carrying load there would be hyperactivity of brain areas handling the load and that would cause increased mitochondrial oxidative phosphorylation. There would be redox stress and cellular stress, and hyperactivity of brain area handling the load would cause increased cellular protein recycling that would cause ER stress response, and both of them combine to cause cellular stress, and this cellular stress would be sensed by NLR, which is a kind of pattern recognition receptor, and there would be resultant DMP pathway activation. This DMP pathway activation would cause NLRP3 inflammasome activation in endothelial cell via microglial activation, and via microglial activation would also cause activation of astrocytes. That would also again cause neurovascular coupling. Neurovascular coupling means dilatation of neuronal vasculature in response to increased metabolic demand of brain. Now, there would also be modification of extracellular matrix and fenestration of perineuronal net, which would cause neurons to form new synapses. Now, microglial activation would also cause activation of neural proliferative zone, activation of neural proliferations and neural stem cell. There would be neurogenesis and gliogenesis, and these new neurons and new glial cell would migrate to zone of hyperactivity by active and passive neuronal migration. There would be new neuronal cells settle down in zone of hyperactivity and synaptogenesis. Now, synaptogenesis would be remodeled by long-term potentiation and long-term depression, ultimately would lead to neuroplasticity, and brain would adapt to homeostatic load. Now, these processes failure would lead to all the symptoms. This failure can be physiological, can be pathological. Physiological is what happens when there is physiological failure of cerebral adaptation. It only happens when the functional demand is sudden, when the functional demand is unexpected, when the functional demand is excessive, when the functional demand is meeting a pre-existing faulty system, when the functional demand itself has damaged the system. Among these, 1, 2, 3 would be best exampled by grief, and 4 and 5 would be where we are going to treat, because this physiology would go into pathology. 5 would be any cerebrovascular accident or any trauma, cerebral trauma, or any viral infection to brain or things like that. And pre-existing faulty system would be genetically vulnerable people have undergoing physiological failure. In physiological state, brain goes into hyperdrive and create a state of cerebral excitation. All the physiological steps in cerebral adaptation to increase functional demand would go into overdrive. The most uncomfortable for the brain is hyperactivity of synapses and neurons to manage this excessive information load that any functional demand present, and they would manifest at the level of functioning that brain expresses. Means, let's say my brain is not able to handle death of my mother, so it would go into hyperdrive and produce various symptoms, panic attack, low mood, other things, which we classically associate with DSM and ICD codings. But that is physiological, and my system would recover in 2 to 3 months. Now, so it is a physiological thing. Now, can we differentiate between physiological and pathological failure of brain adaptation? Unfortunately, at this stage, there is no clear-cut way. Retrospectively, we can differentiate between those two states. There is no quantitative or qualitative way that would predict at this moment. The time criterion of 4 to 8 weeks is very weak and largely inaccurate, but it is the only practical way. If within 4 to 8 weeks I recover, then I probably do not need any treatment. In this area, Pathological changes and physiological changes are seamlessly blends and form a continuum with no line between physiological and pathological. That is why we medicalize most normal life events. And this is why we are blamed that we are over medicalizing. But the opposite is true too. Many a time we normalize pathological condition because again of this overlap. So different level of dysfunction symptom. I am talking about dysfunction symptom. There will be cognitive dysfunction, emotional, motor, sensory, behavioral, visceral, all the area that brain operate. Cognitive, emotive, behavioral symptoms are the same dysfunctional symptom. So I am clubbing them together. It is common domain, and your whole brain is involved in cognitive functioning and emotional processing and expression as behavioral and motor symptom. Learning, memory function, executive functioning, goal-directed decision making, all are part of emotional and cognitive process. It's just an overview. Detailing everything at present is not possible because then we are going to sit here for 7 days. And Alim would die of boredom by looking at his own face. So, most prominent cognitive, emotional, and behavioral symptoms are hypervigilance, followed by central autonomic system, cortical regulation, hyperdrive, and prefrontal cortex to hypothalamus to brainstem mediated arousal and awakening circuit. All modulators of these circuits, like some parts of basal ganglia, cerebellum, midbrain, and brainstem nuclei, etc., these are also differentially involved in this process of hypervigilance. And hypervigilance means I would notice everything that is going around my going around me, and that would make my brain exhausted. The brain regions involved in neutralizing and mitigating these hypervigilance response, like thalamus, various prefrontal cortex area, stops their job of controlling this hypervigilance, and they try to do other activities because they try to conserve their energies. There is hyperactivity of midline cortical areas and their connection with insula and anterior cingulate. This is the proverbial autobiographical area or self area. Now, this hyperactivation of self area causes increased self-referential process or increased autobiographical process to dominate the resting thought process. There is also hyperactivity in the connection between subgenual prefrontal cortex and default mode network, along with hyperactivity in insular and cingulate connections. This is associated with rumination and thus enhances the autobiographical process. There will be decreased prefrontal cortex mediated inhibition of basal ganglia and hypothalamus and brainstem mediated hedonistic urges. This causes impulsivity. Initially, there would be impulsivity. Later, in later phase, the impulsivity would be automatically controlled by habenular feedback loop, and anhedonia would predominate. Other prominent cognitive, emotive, behavioral disturbance would be increased fear, resultant avoidant or aggression behavior, increased failure of dynamic decision-making process, compulsive action and speeches, lethargy and tiredness and forgetfulness, inner restlessness and agitation, increased physiological mindfulness and REM sleep, and early morning awakening due to that, along with nightmare, because REM sleep is more during morning. So what happens that when REM sleep duration increases, the morning REM sleeps become lighter and lighter, and that causes early morning awakening. And the physiological mindfulness is also known as hypnic jerk. It comes when a person is trying to sleep. Now, disturbed circadian rhythm of every single organ of body, including brain, would also be part of this emotive behavioral disturbances. I know these are just basic things, but if you just try to understand these things, you would get answer of many of your queries. For example, why there is early morning awakening in anxiety and depression and things like that. So, what are the motor symptoms? fidgeting, pacing, and inability to rest long, increased physiological tremor, increased activity at neuromuscular junction, resulting in frequent muscle pulls all over the body and spasm of axial muscle and other slow twitch muscles, which stays in prolonged tonic condition. That is why there is increased pool of gastrocnemius and soleus during sleep. That is why there is low back pain. That is why there is various other pains all over the body. Fasciculation and twitching of fast twitch muscles like eyelid and facial muscle. That is why there is eyelid flutter whenever a person is anticipating or fearing something. And that has created some fantastic, I would say, misconceptions. Spasm of muscles of mastication would produce bruxism as well as bitemporal pain and tenderness. Sensory symptom, hyperacusis, misophonia, and startle response. Tactile hypersensitivity and fornication in extreme cases. Now, these are the things which gives rise to cocaine bugs, mate mites, or delusional parasitosis, because the basis is same: tactile hypersensitivity and crawling sensation inside skin. Visual aberration and inability to see at distances accommodate spasm, which sometimes raised in, intraocular tension. And conveniently, our drugs are responsible for this, that are blamed for this. Pain in the eyebrows and forehead due to same accommodative spasm. Depending on supraspinal sensory system functionality, sensory modulation system functionality, either there would be hyperalgesia or hypoalgesia to pain symptom. This is why most people who are anxious are also sensing pain more, and this is also why the so-called patients of autism have less pain sensation. Depersonalization and derelation based on central autonomic excitation and thalamic amygdaloid basal ganglionic excitation suppression by prefrontal cortex. I'm not going into details of it, but maybe someday. Today, we are going to something else. Visceral symptom, also known as famously known as functional somatic symptom. Cardiac, intrinsic nervous system, pulmonary intrinsic nervous system. I am not going into detail of it, but you know each of these. In heart, there would be tachycardia, as well as increased cardiac output, as well as there would be cardiac fatigue. In lungs, there would be bronchoconstriction. In lungs, there would be increased alveolar pressure and alveolar chance of alveolar collapse is more, and chance of basal atelectasis is more. So to maintain that, there is partially breathing, and that creates dryness of mouth, and ultimately this is what creates all of the panic attack. Enteric nervous system would create the irritable bowel syndrome. Reticular intrinsic autonomic cardiac nervous system, reticular endothelial intrinsic autonomic nervous system and brain interaction would produce leukocytosis, would produce increased ESR that we see. Hematopoietic intrinsic autonomic nervous system would produce iron deficiency anemia or anemia of chronic disease. The anemia of chronic disease occurs because what happens is ineffective erythropoiesis is there because of hyperactivity of this pathway, and ultimately there is low bone iron, low production, and failure. Genitourinary intrinsic autonomic nervous system and brain interaction, a huge topic. I am not going into details of it, but it involves all the number one, male infertility, male erectile dysfunction, female sexual problem, menstrual problem, adenomyosis, even to the extent of endometriosis, and along with that, PCOD. Whole vascular intrinsic autonomic nervous system and brain interaction would produce a lot of things, and dermatological would also produce various things. Amongst that, acne is very important. These are cardiac. I am not going into details of it. These are pulmonary. Again, I am not going to details of it because today we are going into treatment. But all of them are important. I'm just showing it because I have already talked about it. I have to hurry because my time limit is 1 hour. This is genitourinary system. Genitourinary system is also the genitourinary intrinsic autonomic nervous system is also responsible for preeclampsia and eclampsia in mother. This is the reproductive brain. These many hormones are involved here. This is the median preoptic nucleus and infundibular nucleus and their interaction with GnRH producing hormone, and the circuit is known as Kindi circuit. Not going into details of it today. This is modified view of Kindi circuit. This is vascular intrinsic autonomic nervous system and brain interaction. And this is dermal. So this whole bunch of systemic manifestation are ignorantly called by us as depression, low mood, literally an anxiety, panic disorder, and phobic disorder, and whatnot. But by now, I hope I have been able to show you how deep all these things go. And brain lies at the center of it. If you have seen the slide, you would understand that you are seeing almost all diseases of body. Now, the lifelong genetic trait, which is there when there is genetic defect in many of these pathways causing this periodic problem, that would be these genetic trait would be hypervigilance, excessive rumination, periodic anhedonia, sticking to fixed routine and rituals to avoid sudden changes, perfectionism to avoid sudden destabilization and acute stress. And this is known as obsessive compulsive personality trait. Neurologists call it Parkinsonian personality trait, as well as the neurodegenerative personality trait. So, if it is a lifelong trait, then what was there in neonatal period, infancy, and childhood? Till now, many of my slides you have seen before, but this onwards is first time. So in neonatal period, there would be poor neonatal assessment score like APGAR score. Various neurodevelopmental assessment scores are there. They would be also low. Few of the developmental pediatricians are already working on this correlation. But as usual, they are doing it more psychological. Prolonged neonatal jaundice and other complications. Poor circadian rhythm establishment, and most affected infants stay awake and are hyperactive at night and sleeps during day. If you ask mother and father of these child won't come to you. Their parents would be your patient. Ask your patients how your child is sleeping at night, and you would mostly hear the child is not sleeping at night, staying more active at night, staying frequently feeding at night. The mother or father has to stay awake whole night to care for the baby, and that is making them very exhausted and other things. The more genetic loading is there, the longer is the night waking period. In severely affected infant, this period can last for 1 year, 2 years, or even more. Now, poor feeding and frequent regurgitation of food and milk. This is again happening due to increased enteric nervous system and its brain and interaction. But ultimately, the baby is not feeding and is cranky. And the neurodevelopmental screening would always stay low. Then comes early infant period. The first sign the mother should observe is delayed social smile. Most mothers do not notice it at first, but when their second non-affective child is born, or when there is a first non-affected child, mothers do inform that there is delayed social smile, that delayed eye contact too, and delayed social smile and delayed eye contact is manifested within first 6 months. Fussy eating habit persists from the neonatal period. There is again frequent regurgitation of food, and these people are very, very choosy about their foods. They have strong likes and dislikes. There is avoidance of social interaction, intense tender intense anxiety of populated areas and other things. Very sensitive to loud noise and extremes of environmental stimulations. At school or preschool age, the separation anxiety gets more. School refusal to leave parents more intense and prolonged than fear. Here, many of you are itching to question me. Most of the children actually cry when they first go to school. Yes, most cry. But how many of them cry so much that the parents had to stop school for a few months? How many of them cry so much that the parent had to stay in the play school with the child for initial few months? How many of them cry so much that they fall ill in school and parents have to take them early back to home in initial stages? If you start asking this question, you would find that yes, most of the children of your patients are showing this. Then come multiple phobias. Then come constipation. Then come childhood allergy and asthma. Childhood allergy and asthma, specifically childhood asthma, require frequent hospitalization, frequent nebulization, is a sure short way to say this child is going to develop various obsessive compulsive trait in within their adolescence with high attention deficit trait. This is almost a sure short way to tell. If you follow a child who started showing childhood asthma from 1 to 2 years of age, by 13 or 14 years of age, that child would show obsessive trait, compulsive trait, and impulsive trait. Frequent infection, insomnia would continue. Pre-adolescence to early adolescence, migraine starts, tantrums increase, social withdrawal and perfectionism sets in, phobias increase, anger and obsessive tendencies increase, and finally, the adult obsessive compulsive trait manifests during adolescence period. So, this is all a spectrum. So, the ones with severe genetic defects in brain adaptability to social and physical and internal environment are labeled as autism spectrum. And the rest moderately affected ones become a hotspot motley group of obsessive compulsive personality trait. So what we are seeing as obsessive compulsive personality trait are the less affected one and the severely affected one are already undergoing occupational therapy, other therapy, and various other things for label of autism spectrum disorder. Am I understood? Have I been able to show the spectrum? So, with this hurried basic cover, I hope you can see the humongous polygenic polysystemic syndrome complex we are treating. Don't ever underestimate these things. They are the biggest diseases of brain and body. If I start showing the other connections, you would find cancer at one end, rapidly progressing diabetes and hypertension killing people at another end, various COPDs at one end, various kind of autoimmune diseases at one end. This is the core, and those are the extensions. I am not going to those extensions today because that would make you say I have qualified for getting admitted in CIP as a patient, but that is true. Anyway, so this is a polygenic polysystemic syndrome complex, and there is no algorithm at present. We haven't even realized what we are treating with. I am just trying to show the picture. So we need a whole pharmacopoeia to treat these things. And for now, in next slides, forget every picture of stall, forget every guideline, and only think with your brain, your scientific understanding, logical reasoning, lateral analysis skill, and scientific knowledge. When to start treatment and what is possible now. When to start treatment, and we are in a soup, because with this knowledge, it is inevitable that ideal treatment would start at least with conception of zygote. But who would let us treat a zygote? Nobody. It should also include preconception discussion and parental treatment. But we don't have any permission now to administer genetic engineering. Neither can we deliver any medication directly to fetus. So what we need to do is treat the fetus through mother. And here comes the failure of perinatal psychiatry, because perinatal psychiatry has become perinatal psychology. Drugs should never be stopped. These are essential drugs for baby and mother. If we stop our drugs, we are responsible for all the things that is going to happen to baby and mother in future. Nobody stops antihypertensive. Nobody stops drugs for SLE. Nobody stops drugs for cancer. And I have already shown these diseases are root of these things. So their drugs should not be stopped. Failure to continue medication is fetal neurodevelopmental trajectory abnormality and ultimately cause the underlying genetic condition to become full-blown sometimes in future. Maternal health would not be spared. She would be more prone to a lot of pregnancy complications. There would be preeclampsia, there would be eclampsia, there would be pregnancy-associated hypertension and gestational diabetes, as well as every other condition. Ask each of your patient who is going through pregnancy. You would find very high history of preeclampsia, very high history of eclampsia, very high history of pregnancy-associated hypertension, very high history of hyperemesis gravidarum present till third trimester, which is unusual for it. There is also swelling of whole body. There is frequently early amniotic rupture. There is frequently loss of contraction of uterus during actually labor period. Just ask your patients and don't believe me. Never believe me. Ask your patients, they would guide you. Now, mother without pre-existing psychiatric condition, but pre-existing severe non-communicable disease and the family history of multiple non-communicable disease is a problem, because the considerations are tricky and we have to keep the medical and legal aspects in check. This should be offered as psychiatric evaluation as fast as possible and should be offered psychiatric treatment. If any doubt, provided they are willing, we cannot treat them forcibly, and we have to be in frequent communication with obstetrician, physician, and pediatrician, because they are the people who would refer these mothers to us. Otherwise, we would not be able to treat these mothers. These mothers are more prone to all complications and their body because they are showing the downstream abnormalities. So they have the brain abnormalities, but undetected. Now neonatal period. This is the second most crucial stage of intervention, but again, major issue is we almost don't know what to give and do. Only practical solution is melatonin at night for the early sign of delayed establishment of sleep-wake cycle and prolonged nighttime awakening with more activity at night and less activity during the day. But then comes two questions: how much and how long? I don't have any answer. I myself give the children of my patients who have started showing this problem, that delayed establishment of sleep-wake cycle. I myself give melatonin. The range is from 1 mg to 5 mg. I haven't gone beyond 5 mg. But problem is the sleep-wake cycle gets normal, but other things are not much improved. Maybe in some the other things are averted, but if the disease doesn't come, there would always be question whether there was really disease going to come or the preemptive measures work. So if there is no disease and no cure, then preventive use has no justification. Now, early infant period. This is when the ones with most severe genetic loading present with prominent eye contact abnormality, repetitive behavior, fear, and other symptoms of a functional deficit brain with hyperarousal, hypervigilance, and rigid and visualistic cognitive and emotional process. PET comes the tag of autism spectrum and the usual rate of thousands and one therapy start playing with the children to mold them into something. Medications are feared. Psychiatrists fear it. All remedial workers and psychologists are dead against it. But what about the fear, rigidity in behavior and anger outburst? What about the restlessness and attention deficit, which is covert or overt? in each and every child with a stamp of autism spectrum symptoms. What about the significant allergy and inflammatory symptom that affect this child? What about the various bowel symptom? What about the other multisystemic complication? If anyone wants to do a multiple system inflammation in children post-COVID, he or she would find out that these people who has so-called autism spectrum symptom, they are affected more. But due to our no medication policy, we are failing to treat it. Which medication to give, how to give, it is still a question. But we should at least try. We should at least try to give fluoxetine drop. We should at least try to give risperidone drops. We should try to give other antidepressant if possible, so that the baby gets a chance to fight the future that is awaiting for the baby. Play school to school age to adolescence. Most children who meets the severe genetic loading grade but has some amount of genetic loading will start manifesting their portraits this time. And any psychopharmacologist worth their salt has to start treating the trait with appropriate treatment, with a fond hope that with appropriate use of medication, the developing brain would adjust to a new functional capacity, and after adolescent age, that is 20 to 25 years, the brain would not face difficulty in handling its functional load without any medication. Unfortunately, in my experience, few brains do achieve this balance. In few adolescents whom I started treatment, I managed to withdraw the drug. In most, I could not. I don't know what is your experience, or what if any of you have tried to change the trajectory or not. And the problem is again the same. If I continue medication and then withdraw and the brain is stable, my question would always remain to myself, was the medication needed? Could the brain itself have managed it after a few years? I don't know. I don't have any answer. So how the first episode presents typically? Obsessive compulsive personality trait can be divided into with prominent secondary attention deficit trait, without prominent secondary attention deficit trait. These are the main two categories of patient we face. There is always some attention deficit trait, remember that. But with secondary prominent, we need to address that fast. Without that much prominence, we don't need to address it fast. With secondary attention deficit trait prominent, the presentation would be like so-called borderline personality, with body focus repetitive movement, with impulsive compulsive trait like addiction to substance or behavior.
Sir, sorry
Yes.
to interrupt. 50 minutes are done, sir. 10 minutes pending.
Okay.
Thank you, sir.
10 minutes probably would be enough. Recurring low mood and overthinking associated with periodic hyperactivity and a dreaded bipolar 2 tag. Obsessive compulsive personality with very high attention and dominance need and narcissistic tag. These are the way secondary attention deficit prominent people with primary attention deficit present. So with primary obsessive compulsive trait present. This is also another presentation, but this would come later in next episodes. These same group of people would also present with acute onset fast episode mania or psychosis. Now, without prominent secondary attention deficit trait, the people will present with gradual onset, deepening sadness with multiple episodes of severe anxiety and panic attack, multiple body aches, abdominal symptoms, other bodily symptoms, and lethargy, gradually worsening obsessive compulsive symptom with very much withdrawn behavior, sudden or gradual suicidality with any of the other three groups. As usual, there is another hidden one. The gradual onset psychosis or the early psychosis means rigid fixed behavior followed by attenuated psychosis or other ultra-high psychosis followed by psychosis. That group also falls here. But again, we are discussing that on a later date. So how to approach? If possible, from today onwards, forget the psychological trauma and erase it from your non-existent mind because trauma doesn't cause it. Only important trigger that needs to be taken seriously is infection, other systemic disorder, and major injuries to brain and body. Listen to soft stories of patients for a few minutes, but they are just stories and nothing else. These even didn't do anything. You are listening to soft stories for their comfort and their trustworthiness because you need that. Take full history since birth and the crude three-generational family history of every non-communicable illness along with psychiatric symptoms. Then note full body features of patient and be conversant with Waldorf scale and Mays scale of minor physical anomalies. Also learn to differentiate between peripheral minor physical anomalies and minor physical anomalies in craniofacial region. As you learn slowly to apply this scale with confidence, you would start noticing various different and expanded minor physical anomalies that are not listed in the scales. And they will be present in patient. I am giving one such example of trait. A patch of gray hair starting from high point of temple and growing backwards. It is a sure sign of severe level of obsessive compulsive trait, which would give rise to psychosis at a later date. And some of the first line relative, first degree relative would surely have psychosis. But there are thousands of other traits if you need, regularly watch for them. And ultimately, as you notice, you'd learn to predict all the symptoms of a given patient when you walk into your clinic for the first time. Gives an amazing placebo effect to patient. This is personal experience. This thing is called clinical genetic dysmorphology, and we are just applying it at the brain treatment. This is a clinical genetics branch. So at last come the pharmacological intervention. Basic understanding of psychopharmacology here. This lady would get my love with, although she has done a very bad job for psychiatry. Now, since none of the basic pathophysiology of generation of the state involve any specific neurotransmitter, and rather it is interplay of thousands of different neuronal proteins, some of which are paracrine, autocrine, endocrine, or juxtacrine in nature, besides being involved in neuronal cellular functions, it is safe to forget those 5 sacred neurotransmitters: dopamine, serotonin, noradrenaline, GABA, and glutamate that you remember from first day of your first year. You don't need to mug it up. And now you are also being trained into endo-opioid and endocannabinoid. Throw them out. You don't need them. Besides, there are literally thousands and so-called neurotransmitter in brain, and hundreds are being discovered each 5 to 7 years. And this lady would get my big shout out because she broke the serotonin edifice. She did a huge job for psychopharmacology unwillingly and unwittingly. Low mood is just a teeny part of the whole body-wide distributed symptomology of these syndrome complexes. And we know it by now. Low mood is even redundant with gross pathophysiological understanding of these symptoms for the decision to start treatment. You don't need to for the patient to feel low to start treatment. If other things are present, you are going to start antidepressant treatment. And none of these drugs elevate low mood by their effectiveness. I am feeling low and I pop a pill of Prozac and mood improves instantly. That never happens, except in Hollywood fantasy. So the name antidepressant has no meaning to it. These drugs work completely different. These are the ways these drugs work. They increase neurogenesis and gliogenesis. They modulate cellular stress sensing and ear stress sensing. They increase and correct neuronal migration. They modify neurovascular. They modulate neurovascular tone and neurovascular unit function. They remodel neuronal and glial microtubules. They enhance synaptogenesis and synaptic remodeling. They modulate and balance cell division, cell growth, apoptosis, and autophagy. They modulate adaptive immunity and crosstalk between immune system and neural circuits. They modulate innate immune signaling and damp PAMP pathway. They manage and modulate extracellular matrix formation and destruction. They modulate cellular proteostasis, and they also manage intrinsically disturbed protein beta. Intrinsically disturbed protein is also known as misfolded protein. They cause epigenetic modification of DNA and RNA. These are the functions. So, what to do with specific syndromic presentation? Patients with obsessive compulsive trait without prominent attention deficit trait. I chose it first because with this expansion, the second one would need less space. These people need a layered pharmacological approach. Since we are not dealing with a single disease or even a spectrum of diseases, that we are dealing with a 20,000 plus gene containing network, and God only knows how many zillions of epigenetic changes, it's only natural that we start thinking in format of rational polypharmacology. Monopharmacology cannot treat it. We are deluding ourselves if we say we are treating by one drug. Cornerstone of treatment of this group is so-called antidepressant, but not any antidepressant. Based on their personalized genetic combination, they would respond to only a few antidepressants, and we don't know which of antidepressants are they. There is no shortcut exists to find this medication. If there is more anxiety symptom, then there is a way of selecting antidepressant which have more sedative property. The note of caution would be, depending on personal genetics, sedative properties can change into activating properties for some people. For most patients, even a cheap 1 to 1.5K smartwatch with smartphone integration is best friend for them as well as us, because they show the resting heart rate, the resting body temperature, the motor movement, as well as the sleep tracking. Now, this should make us see when the patient is going into activation. If there is rising resting heart rate, rising resting body temperature, more motor movement, and more REM-associated awakening and more fall in saturation during sleep, this patient is going into activation. And we need to be aware that we need to add something. Otherwise, there would be activation and we will stamp it as bipolar. The game is over for the person. Lifelong, he or she would be suppressed by antipsychotics and so-called mood stabilizer or rather antiepileptics. So be very cautious for activation. The first antidepressants would be supplemented with a suitable autonomic nervous system dampening agent, depending on resting heart rate. If heart rate is below or around 60, prazosin up to 10 mg or ondansetron up to 60 mg helps in some. But none of these are superior to propranolol in overwhelming majority of patients. Some sedative help is needed for patients for those who are not sleeping, and melatonin or benzodiazepine can be used, or non-benzodiazepine. Total, if now of any medication or any surgical procedure is perceived effectiveness of the procedure by patient, that is placebo or nocebo action, plus minus confidence of the teaching physician in that medication or procedure. Less confidence is more cognitive bias for the physician for side effect, as well as for not being confident enough in front of the patient, and less placebo and more nocebo response for patient, plus real effectiveness of the medication or procedure. Why I am saying so? Because antidepressants start working after 4 to 6 weeks. There is no way they are working at 10 days. So your 10-day or 2 weeks follow-up is actually a placebo boosting action or something else, but it is not showing any improvement by drug. If patient is improving, then pat your back, you are a good placebo. If patient is not improving, do not lose hope. You just lack the placebo value, but medication has its work, and medication would surely work. And it is always the highest tolerable dose that works best. Go there, go slowly, but surely. Residual effect after fast drug fully or mostly work around 4 months. Dysphoria and anhedonia, 4 slides more. Dysphoria and anhedonia, attention deficit and forgetfulness, anger and assertiveness, anxiety and panic, residual form, lethargy and fatigue, persistent obsessive compulsive symptom, persistent suicidal thoughts, excessive sedation, persistent pain. These would be the residual symptoms. Now, I would talk about anger and assertiveness in a different way, and rest I would club. Anger and assertiveness is actually sign of improvement. These people are mostly non-assertive and they normally do not show their anger. So if they start showing anger and assertiveness, that is a good sign. Medicine is working. You have to just psychoeducate the family that you are not facing that timid, scared person anymore. This person has a voice, and it's better to accept that voice. Many family members would be uncomfortable. And here comes therapy part, psychoeducation part, and non-pharmacological part. So residual panic, anxiety, and residual obsessive compulsive symptom. Second, antidepressant that suits low dose antipsychotic, increase propranolol, add clonidine, add memantine, add naltrexone, add amantadine, add therapy of patient choice with other medication. These are your options, which would work in home. There is no hard and fast rule yet. We haven't yet reached that area. Residual dysphoria, anhedonia, lethargy, weakness, forgetfulness, anomia, and attention deficit. Modafinil, armodafinil, levomilacipran, bupropion, pramipexole and ropinirole, amantadine, atomoxetine, methylphenidate. All these are also applicable to excessive sedation, but first ensure that the excessive sedation is not due to antidepressant. So first reduce the antidepressant. If that doesn't actually make the sedation go, then start these. Persistent pain, again duloxetine, levomilacipran, milnacipran, desvelnavaxine, venlafaxine, and atomoxetine. Obsessive compulsive trait, with prominent attention deficit. The second sort of presentation. Here, there are two cornerstones of treatment, antidepressant and anti-impulsive medication. The anti-impulsive medication may be naltrexone, antipsychotic, anti-epileptic, varenicline, memantine, lithium, and autonomic nervous system blocker. Which one? That would be dependent on patient characteristics. Again, there is no clear superior drug. Probably naltrexone and varenicline has some edge along with lithium, but again, we have too few data. That C2 is for emphasis to assert anything. Obsessive compulsive trait with prominent attention deficit continue. The main problem of these patients are their addiction liabilities and their various behavioral overuse problems. After sufficient control of obsessive compulsive trait, most of them need to be given specific attention enhancement medication for the control of their addiction deficit. Ultimate regimen for them after a suitable time frame would contain one antidepressant, one anti-impulsive medication, one attention enhancing medication, and an optional autonomic system blocker. And I am talking about 6 months to 1 year down the line of treatment. Notable omissions. Various endocrine system and their destabilization management, pathophysiological formulation and management of slow progression psychosis and mania, pathophysiological formation and management of acutely emerging psychosis and mania, adolescence onset discussed, but I have not discussed adult or middle age onset, metabolic syndrome association, I have not discussed, neurodegeneration and evolution of various dementia syndrome, I have not discussed, systemic complication in form of non-communicable diseases, not discussed. I have also not discussed ketamine or LSD or magic mushroom or various euphoria. They occupy a special place because I wouldn't have finished this presentation within 1 hour then. Thanks for bearing the verbal torture. My presentation ends here.
Thank you so much, Bhaskar. Thank you so much. At least today,
As Bhaskar had promised, is the best presentation of Bhaskar. Let me be honest about it.
exactly, because at least either all the slides were understandable, or at least some portion of it was understandable. So
I have made this slide specifically so that it becomes understandable. I have not added.
अलीम और अमृत का IQ के लेवल का बनाया पहली बार. Thank you.
Well, thank you. Over to chairpersons.
Yeah. Thank you, Bhaskar. It was quite nice. And of course, keeping in line and keeping in tone with whatever you have been telling us and the previous presentations that you have made on this platform and elsewhere. Very interesting. So this is what actually psychiatry is. It is the longitudinal part of things, most of which we probably do not give so much attention. Nicely summarized what was interesting, and of course, I think we can have more on. There have been so-called sequential treatments for depression in the literature, but this is what actually it means, that over a period of time, what we are looking at, what remains, what needs to be treated, what needs to be modified, and things like that. And it's not that one drug is going to suit all. It's not going to be one drug all the time. Let's see if we have some questions. There are
25
questions.
There have been
I
25
don't
questions.
know. 25 chats. I have not seen anything.
Yeah. So, well, most of them have been good evening and congratulatory messages. Dr. Ashok Kumar has asked, do we have a primitive octopus-like nervous system? Do you want to reply to that?
Are we?
Do we have a primitive octopus-like nervous system?
We don't have a primitive octopus-like nervous system. Rather, I would say we have a octopus-like nervous system made 1,000 or more times more complicated. Yes, like octopuses, we also have peripheral nerve centers, which we never talked about. Cardiologists are the first one who are talking about intrinsic cardiac nervous system, and that too in last 2 to 3 years. And intrinsic nervous system of every organ has not been talked yet, which I talked today. So yes, it is like octopus, but it is much more complex than octopus. Rather, it is something that is combination of both. Octopus like peripherally distributed glands along with a central brain which controls everything.
Yeah. Alim, you had something to say?
Yeah. Bhaskar, you in your presentation many things. Suppose I take this thing. You said ki we should try and take control or treat the traits that are occurring so that the future evolution of illness is modified.
I missed what you were saying. I missed actually.
Can you repeat? Can you repeat, Ali?
Can you repeat?
Yeah. So what one take home message was that you start treating the traits so that the future evolution of illness is
Yes.
manageable, is
Yes.
controlled. Basically,
Yes.
you're talking as a disease modifying agent. We are using our medications.
Yes. Our medication are disease modifying agent, but in a so grand scale that I am myself is still, I would say, amazed. There, but because that is the most what I can say. I am not that much expressive in my emotional capacity. A group of drug that can modify course of every non-communicable diseases of body. Can you understand the implication? A group of drug which can modify course of development of hypertension, a group of drug which can modify course of development of diabetes, a group of drug which can modify trajectory of development of cancer, a group of drug which can modify trajectory of development of infection. This is like something that is, I don't know. And I am not saying this just by my scientific logic. Alim, you yourself have presented those papers because I have sent you those papers.
Yes, definitely. I'm asking for the audience benefit. So now the thing is, you start giving fluoxetine to newborns, preschoolers. So then again comes a host of problems. So,
Yes,
what is your take on this now? We
very
can't
big problem.
drop in the water.
Very. Hmm. Hello, hello. Yes, someone is talking. Hello.
Should we mix the fluoxetine drops in the water supply?
We cannot, because how much the idea is interesting. The idea is very much interesting, but the
I think there is some connectivity issue.
Dr. Ashutosh wanted to ask question.
Yeah, but I think Bhaskar is lost.
Yeah. Bhaskar, Bhaskar,
Am I audible?
No, you are not. There is some
was
problem.
break.
Am I audible?
Yeah, right now you are. There was a big gap.
So you again repeat the statement.
Okay. Let me check. Yes, I have stopped the video. Let's see if
Yeah,
that
you're
helps.
audible now. You're audible now.
Am I audible?
Yeah,
Yes.
you're
Yes.
clearly audible.
Okay. The thing is, human being is a rapidly degenerating species as a species, because we have
Yeah, it's gone again. Bhaskar, you're not audible. I think there's some problem.
Malay boss, a query for you. Bhaskar was talking about stress and various in various cellular dimension it is expresses.
Hmm.
So this problem in synaptogenesis, can you give a brief summary of that? Stress causing intracellular actions.
So basically, what Bhaskar has been trying to say in very brief is that, first of all, what we understand by stress, it is not an external situation, but how our systems are responding. So any challenge.
Am I audible now?
Yes, you are. Please continue. I'm not taking over. Yes.
Actually, the thing is, somehow my network connectivity dropped. Okay.
Yeah.
I was talking about a human being and the evolutionary bottleneck we are in. In development of every animal species, every dominant animal species in any planet, there comes a situation when the animal species has conquered nature in killing it. Means natural way of killing that animal by its surrounding environment is limited. Human being has reached that level. So nature cannot kill us by various infections, cannot kill us by various natural calamities and other things. But every human being has a genetic makeup, and that genetic makeup contains rare variants as well as common variants of various diseases. Now, what happens is, in human being, due to our longevity and our prevention of natural culling, this rare variant of disease is I would not say slowly, rapidly going into population gene pool, and our genetic quality is rapidly deteriorating. That is why there is so much tremendous rise of non-communicable disease in successive generation. Now, so if we mix fluoxetine to water supply, there might be help, but the problem is 90% of people would not respond to fluoxetine because it is their personalized genetic makeup which decide which drug would help them. So standing there, mixing fluoxetine has no value. We have to overcome this bottleneck by starting to apply various genetic engineering in our future generation. But for next 1 or 2 generation, we are in bottleneck and we are going to suffer. So,
Okay.
sorry,
So
Ali,
no
that
problem.
was
Yeah. So a couple of questions by Dr. Divay. One is, how does whatever you have talked about today explain mood fluctuations in bipolar disorder and antidepressant induced mania in brief?
there is no antidepressant induced mania. There is antidepressant induced activation. I have talked about activation today. The rest of the part I would talk in later episode where I would discuss only mania and only psychosis. That
Okay.
is why today I have left mania and psychosis.
Okay. Dr. Ashutosh wanted to ask some questions directly.
Can we unmute him? Can we
Yeah.
unmute him?
Can we
Salim?
unmute
Yes, I'm
him? Yeah,
unmuted.
yes, go ahead.
Yeah.
Okay, thank you, Dr. Malay. Bhaskar, first of all, excellent presentation. I did hear your last part when it comes to treatment. So that's where you have said that sequential treatment. And that is where my question is. So when the person is coming to us, he is having all the symptoms. Why do you want to wait 2 months before adding on the, let's say, the second line beta blockers or something? Why not give it right from the day one, 3 or 4 medicines, one low dose antipsychotic, one antidepressant, one propranolol and melatonin? I'm just trying to understand why you're giving this sequential kind of thing.
The problem is I have divided into two groups. Those presenting with all these symptoms in them, I have presented with two groups. One is primary obsessive compulsive personality trait with less attention deficit trait, and primary obsessive compulsive trait with more secondary attention deficit trait. Why I created this divide? Because these people, if they are coming with more secondary attention deficit trait, then by adding multiple medication, you are increasing the chance of activation. And if there is activation, I would say 99.99% of psychiatrists still would stamp that person with bipolar tag. And bipolar is such a tag that once applied to a person would stay throughout their life. Throughout their life, they would have to be subjected to various anti-epileptic, various antipsychotic, various kind of restrictive drugs, which would reduce their cognition, which would reduce their functional capacity, and ultimately would ruin their life. That is why I would try to prevent that end of a human life. So,
Bhaskar,
sequential treatment.
what do you mean by secondary attention deficit?
Secondary attention deficit means actually there is a primary attention deficit where the brain's primary fault is attention deficit, and there is a primary obsessive compulsive personality trait where the brain's primary problem is brain cannot meet up the functional demand of its surrounding environment, and it creates a structured space where it works better. Now, in both the group, be it primary attention deficit or be it the primary obsessive compulsive, once brain is restricted to a specific setting, brain tries to adjust itself. Brain, like every other organ, is plastic, very much plastic. Initially, we thought brain doesn't repair itself or doesn't change its aspects, but now we know brain is plastic. Now the plasticity of brain would cause the primary attention deficit brain to develop a secondary obsessive compulsive trait, so that it doesn't forget much. It would try to limit its novelty seeking behavior. It would try to restrict itself, and there would be some form of functional balance. So every primary attention deficit trait would come with secondary obsessive compulsive trait. Either the brain has repaired itself enough and the secondary trait is at almost balancing the primary trait, or it is not. Similarly, in a primary obsessive compulsive trait, the attention deficit trait is actually compensatory mechanism, but the compensatory mechanism many a time doesn't really help the person, and rather create a new sort of set of problem. And that is what I am meaning by primary trait and secondary trait.
Okay.
This is very gross. I am not going into finer details because these are very new things. I don't want to go make it more complicated.
Pregnancy, if symptoms left untreated, so how does it? Why should it affect the newborn child and later on its development? What damage untreated psychiatric symptoms?
Any untreated psychiatric symptom
in
mother would start first with implantation. That is the first area that would get affected. When zygote converts into blastocyte and gets implanted into mother's endometrium, there is a reciprocal and receptive maternal immune relaxation. This is why most autoimmune diseases start going into remission when there is pregnancy. Now, which organ does this receptive maternal immune relaxation? Unsurprisingly, it is brain. Through various intrinsic autonomic nervous system of genitourinary tract, in endocannabinoid system and endoopioid system, it causes that immune relaxation. So if we do not, for reference, I am giving one name, leukemia inhibitory factor or leukemia inhibitory hormone, LIH or LIF. Read about it. Gynecologists are very much aware about it, but gynecologists do not know that this is an endocannabinoid. Anyway, through these, the maternal immune relaxation is happening and placenta is forming. So, if brain cannot manage that process, if brain is functionally deficit, then implantation will not happen. That is why so much of the IVF is a failure, because in IVF, the brain is in huge stress because of induced ovulation. Induced ovulation, the drugs which are used in ovulation induction, they cause havoc in brain. Be it GnRH agonist, be it clomiphene citrate, they causes cerebral discomfort. Similarly, these patients, if they have untreated depression, untreated brain dysfunction, that would cause the same thing. Then comes early pregnancy loss. Again, early pregnancy loss, the various early abortions, they are again happening due to placental abnormality, most of which is genetic due to fetal and maternal problem. Again, there is role of brain, and again the blood supply of placenta comes from the internal ilia cataries and common ilia cataries. These internal ilia cataries and common ilia cataries, the uterine artery, they are torn if not maintained properly by intrinsic nervous system of vascular system.
So,
brain.
certainly here, certainly in the mother who has depressive symptoms. So, will this prognosis improve?
If
prognosis
if you give,
if we add sertraline in such a patient, will
if
the outcome?
the patient respond, if the patient is suited to sertraline, if the patient respond, if the patient's brain started working more, which would be seen by their functional improvement and other things, then prognosis improves.
Okay, thank you.
Yeah, one question by Dr. Savita Malhotra, ma'am. Is there what are the implications from the primary prevention perspective?
Primary prevention perspective needs more genetic research into genetic engineering, more research into making genetically resilient baby, more research into perinatal period, and be pro medication at perinatal period. Unfortunately, 99.99999% of perinatal psychiatrists work as psychologists, and they just go ballistic in the name of medication. So unless we change that, there won't be any primary prevention. We would be talking about secondary prevention, that is diagnosis and treatment. But there is a huge role of primary prevention, and ultimately we need to develop primary prevention. because there is no other way. Non-communicable diseases needs primary prevention.
Thank you.
Yeah. Yes, Ashutosh.
Yeah, Bhaskar, just to continue on the previous question. So suppose we have given 4 or 5 different kinds of psychotropics to the patient and he's now settled down, he's doing well for say a year or so. And suppose the person expresses a desire to cut down the medications and in a calculated. So let's assume that this is the first episode of depression.
Which category? Obsessive compulsive without secondary attention deficit,
Yes.
or which secondary?
Yes. No, without
attention?
the secondary attention deficit, without the deficit.
Without
Yes.
secondary attention deficit, someday we can.
Yeah, my question actually is,
we can reduce the attack.
right, but which one
Yes.
should we start reducing first? So suppose I have given a person propranolol, I have given him olanzapine, I have given him 2 different antidepressants. Which one should I start first to taper? That is my question for you.
First tapering off would be propranolol. Why? Because it would give us an idea whether any tapering can be done or not. If you reduce propranolol and taper it off over a period of 3 months, and the person started having some symptoms, then there is no chance that dose reduction can be done. And with reduction of propranolol and omission of it, if some symptoms return, you can easily manage it via reintroduction of propranolol. This is the easiest one to do it.
And after propranolol, what next?
After propranolol, in this case, olanzapine.
Okay, thanks. Thank you very much.
Okay, one last question from Dr. Dinesh Kumar. Do ERVs have a function in immunoprotection as well?
What do
ERVs have a function in immunoprotection as well?
Endogenous retroviral. They have their function. They have their own immune function. Many of them act as immune checkpoint protein. Many of them have their own role in various immunotolerance. In fact, ERV is indicated in a lot of autoimmune diseases, loss of function of ERV, as well as in some cases gain of function of ERV. So standing there, yes, they have their immunoprotective action. That are immunotolerating action. They causes immunotolerance.
Okay. So I think we are done with the questions. Suyog, over to you for winding up, last words, take home message.
Thank you very much, sir. That was really a wonderful session. It takes me to something to think about. Psychiatry as we know it. We have learned psychiatry from symptoms to disorder and to disorder to symptoms and then the medications per se. Now there is a whole different neurodevelopmental perspective, thinking psychiatry and symptoms in terms of the core molecular reaction and the encoding of different proteins as such. Knowing neurotransmitter from more than 1, 2, and 2 and infinite number of those, we are still in a learning phase. I really appreciate your enthusiasm of starting treatment early, even before the symptom appear. Probably at some point of time we may end up calling psychotropics as neuromodulators or psychomodulators or something of a similar sort maybe. And I would really want to thank you, sir, for having such an enlightening session. Thank you, Tofan Pati sir, Alim Siddiqui sir, and Dr. Amrit Potti Joshi sir as well. And thank you, Male Dave sir, for co-chairing the session with me. It's really a pleasure to chair the session from someone that you have learned a lot from. Thanks a lot, sir. I think we can conclude the session today.
Yes. So no more comments from my side. Over to you, Aleem and Amrit and Dr. Tofan Kati, sir.
Tufan sir is actually not here, so you have to conclude.
I think, Bhaskar, I would like to congratulate you. Your knowledge and your presentation was it was in sync. Actually, many times what happens is you know so much, but the presentations are sometimes the people like me and Aleem, it's too tough. You do some partiality by sending some papers to Aleem early, so he's able to understand a little more than me. But for people like me, it's almost Greek when we hear things. But today, it seemed that you have taken a lot of effort. You came in time. You are dressed so nicely. You're looking so handsome. Your presentation was chic. You deserve 100 today. And from primary prevention to the tertiary part, you spoke about everything from diagnosis to that's wonderful. I think that's how we can take this passion of yours further. I think, and today was the best advertisement of how you can do things. And we are proud of you. Malay sir, we need him always when you are there. And thank you, Suyog. It was wonderful having you. New pace, you're a head of department of AIMS, and that's a big thing. And most of the people in India are a student of Malaysia. So you are a direct student. We are all indirect students. Thank you so much. It was Navaratri, tough subject, tough presenter, and then we had more than 100 people who were glued, and we have very less doubts because it contained everything. Thank you so much for coming, joining, and being part of this wonderful journey of ours, Thursday Musing. Thank you, Torrent. Have a great Navratri, ending of Navratri. Have a great weekend. Meet you again. Next month is Autism Month. We have made a special autism things. Bhaskar will not like it, but he has started it today with a lot of talks on autism. And I like the very way he talked about medications. People are shy of giving medications, and then 17, 18 years goes away without they improving in anything. And I think Bhaskar has given the very beginning which I wanted to have. So thank you, Bhaskar, again. Thank you, Malay sir. Thank you, Aleem. You asked all the questions, all the doubts. At least he allowed me to say thank you. That's so nice of him. Good night.
Good night.
Good night.
Bye.
Bye bye.
Bye.
Good night.
And I am going to catch train. Bye bye.
Bye. Closing the meeting.
Thank you.
Thank you so much.